Hi, everybody. I'm going to present to you my genitourinary PowerPoint. Before we get started on the actual PowerPoint, I want to share my screen and kind of go through all of the documents that are on Blackboard and just all of the topics that you'll be responsible for this test. So first thing is I just always want to remember to go back to your syllabus, right? And these learning outcomes are the outcomes that are also listed in your PowerPoint. But just to point out for the genitourinary system for adult, you will be responsible for UTIs, bladder cancer, renal calculi, urinary diversions, and then also the male structural disorders. Okay, so phimosis, cryptocortism, and hydrocele. Okay, the rest of those things are all under pediatric, but just as you are going to your reading, you want to make sure and you're studying that you are paying attention to all of that. I also want to bring bring you back to Blackboard into my folder. Let me just get to the right place. Sorry, I have a lot of things open here, so I'm going to have to keep going back and forth a little bit. Okay, let me get onto Blackboard. As you know, you're going to go to my folder, and in my folder, you'll see the GU lecture. Under GU, you're going to see several different things. So adult GU, if you open this up, you're going to see one that says GU Visual Extras, okay? This is actually a slide as well. And you know, if I was in class, what I like to do is have you see what you can draw and remember of the A and P of your GU system is how I would have started. And I would have also had you just kind of come up with all the things that the kidneys are responsible for, but here it is just in list form. It's not quite as fun when you're watching it on a recording. This is also on a slide, but it's so small that I just pulled it out and have it for you as a separate document. But this is something to pay close attention to of your analysis that we'll be talking about and what is in it and what should be in it and what should not be. Again, just because they're very small on the slides, I pulled out the pictures because I know we have a lot of visual learners and we're going to be talking a lot about the function of the GU system and especially the kidneys and the filtration. So here are pictures. Like I always say, you need that strong foundation, right? So even though I'm not going to be, giving you a visual of a kidney and having you, draw in what the listing of the anatomy is and labeling, you do want to understand about the kidney function and before to be able to understand the pathophysiology that we're going to talk about. And then this last one, I really just liked this picture. It's just kind of a good synopsis overall of the human body's urinary system. So I thought that kind of ties it all together. So if you take a look at that. Now we are going to break it down in the slides and talk about all of these things, but I just wanted to point that out to you. Another thing that I have posted for you, obviously, is the PowerPoint, which I'll be going through today. But I also wanted to, let's see, I gotta go back again, sorry. Close that one out and open another one. As I always do, I have a med sheet. So this PowerPoint, I mean, what am I trying to say? This recording will not be as long as your class would be because we would be doing some interactive things in class. And one of the things that we would be doing is filling in this med sheet. I like to do this with every class. There's not as many for GU, which is nice. But I absolutely recommend that you make sure that you know about these medications when you are preparing. Okay. Next thing I want to show you is, again, another interactive activity we would have done in class. And this is a case study from a case study book that you do not have. But this ileal conduit case study is excellent. I did just give you, cut to the chase. I gave you the answers to the case study. But if you want to, go through and figure it out for yourself. Just don't look at the answers when you are going through. Otherwise, I would take a look at this. This goes over a lot of important points about urinary diversions, which we're going to be talking about. So that is for you as a study tool as well. And the very last thing that I added, it is part of this content, but there's only just one quick slide on it. But I made a little, again, kind of study tool on the male structural disorders, and you're only responsible for those three. So those are the three that are on here, along with the gerontological and safety considerations that you should be thinking about with those male structural disorders. Okay, so that is what we have for us here on my folder. And as you know, you should know me by now, I don't post things that are not going to be important, right? So definitely do not bypass or ignore any of those extra things that I have posted for you. Okay. So what we are going to do here now is I'm going to share the PowerPoint, and we are going to begin by just going through, okay? As you know, these are going to be the learning outcomes that you have also from your syllabus. Like I always say, a great way to make a study guide or to know that you're ready for your exam is to go to your learning outcomes and see if you can answer those questions. All right, so I'll skip over those. So we're going to move on here to your anatomy and physiology. Okay, so you know that your kidneys, you know where they're located, right? And they're just out behind and outside of the abdominal cavity. One thing, actually, kind of reviewing this, I always learn something when I go through, and I've taught this for many years, but I kind of forgot that the right kidney is a little bit lower than the left because of it being a little bit displaced by the liver. The other thing is that knowing what is the blood source, right? So the renal artery is what supplies the blood to the kidneys. And this is kind of an interesting fact, right? So all of the blood in your body is going to circulate 12 times every hour. And each of your kidneys, or with your both kidneys together, is going to receive 20 to 25% of the cardiac output. So that's kind of important to understand this and understand the filtration power of your kidneys, okay? And again, we always say, like, which came first, the chicken or the egg, right? So if you have kidney disease, if you have heart disease, that obviously affects your kidneys, right? If you have kidney disease, that is going to be affected by, affect the amount of blood that it can filter coming from the heart. So, so it's kind of like, it's interesting that you could look at it either way. Also, you're going to want to understand just, again, that A and P, the renal artery, the arterioles, and the glomerulus. So these are what are the actual workhorse of the nephrons, right? And the nephrons are where the filtration is going to occur. There are 1 million nephrons, which is kind of crazy, right? So if you look at that picture, which I don't have the picture right here, but you have the picture, right? And I'll have a picture coming up. But if you look at that picture, so each of those little like tufts of capillaries, okay, is what that glomerulus is what makes up the filtration component of the kidneys. And that's what then ultimately is what creates the urine. Okay. Now, your ureters are quite long if you think about it, right? And this is what prevents the reabsorption of urine, right? So once we don't lose all of the water that everything that's filtered through, and all the water in urine, all the water is not excreted, right? They create a filtrate that forms urine, and that is what you lose in a day. But if we lost all of our water, right, that would be a problem, right? So we need to make sure that some of that, all the water is reabsorbed and kept in our body, right? And then the urine that is produced, we want that to be excreted, and we don't want that to be reabsorbed, right? And that lining in the ureters is what prevents that from happening. The bladder, which we're going to talk about more. I know you guys love when I use these vocabulary terms, but distensible means that it stretches, right? So that's a good term, right? And the bladder capacity is about 500 milliliters, right? And you actually feel like you need to go urinate when it's about 150 to 500 mLs. I want you to think about that for a second, because how many of you have put a catheter into somebody and they take out 900 mLs of urine, okay? And a little side note, if you get to 1,000, you should clamp that tube and allow the body time to readjust and not, the whole system will go kind of into shock and to have bladder spasms if you let too much go too soon, right? Imagine that little old lady who was found on the floor, broken hip, right? And the emergency, the paramedics pick her up and put her into the ambulance, and she gets to the hospital and she has been, lying on that floor for 2 days. And then they go and they realize that she's extremely distended, and they put a catheter in, and they could probably take out 1,600 mLs of urine if she hadn't been incontinent. So that's dangerous for her, okay, with fluid shifts. So, but think about that, right? Like I said, how many times have you put a catheter in and you drew out a lot more than 500 mLs of urine, right? So that is what it should be holding, is up to 500. But because it's distensible, because it stretches, it does hold more. But if you think about, I think about myself like, oh, you're on that really long car ride and you wait and you wait and you wait and wait. And then all of a sudden you have to go to the bathroom so badly and it hurts so bad, right? That's because there's a lot of nerves that are in your bladder as well. And when it's forced to stretch beyond that 500 mLs, that's when you get that pain, right? The bladder also has the 2 inlets, right? So, because from the kidneys, you have your ureters, right? And then 1 outlet, which is going to go down the urethra so that you can excrete. Next is the urethra, which obviously we know what that does, right? But that's where the urine's going to come out of. All right, and here's just that picture that I was talking about, right? And you can see you've got, we're going to talk about the upper and lower genitourinary system today, where we have our kidneys, the ureters, okay, right? And they are connected to the bladder, and then the urethra is the outlet, okay? And that's what we're going to be talking about today. This second picture is our kidneys, right? These are the things that we were just talking about. We talked about, mentioned about the renal artery, right? So the renal artery is what's going to supply the kidney with the blood to filter, right? We've got here the full kidney here. This is the ureter that's going to come out, that is going to go towards the bladder, right? And then within here, this is where we get all the good stuff, okay? And within here, this is going to be what's called the renal medulla. And within the medulla is where you're going to have your glomerulus, or your nephrons, that are going to do all the filtration. And that's what's all in this part, okay? And you're going to want to, like I said, go to those separate pictures that I have. And there's those separate pictures that really break it down even more, so you can see, like in the glomerulus, the loop of Henle, which we've heard about, right? Because furosemide, right, exerts its effects at the loop of Henle, and we'll talk more about that. But I think it helps to understand if you, well, here's your picture, right? I think it helps to look at the picture and really understand what's happening here, right? So this is where, the water is going to be reabsorbed. This is where we lose our electrolytes, and where our urine formation is going to happen. All right, so the kidney, the functions of the kidney, very, very important. There are so many things, and I think that a lot of people don't even realize some of the things that the kidneys have a part in, and how they are then interconnected to things in different systems, right? And we know, like I've said, we can't be thinking in isolation only genitourinary, right? Because the kidneys are connected to all these other body systems, and we want to be thinking about the patient holistically, and all about all different body systems, right? So some of the big things, right? We know we're obviously going to make urine. It helps our body to get rid of waste. It helps us to regulate electrolytes, right? So we always think about the sodium and the potassium, right? Which we're going to lose at that loop of Henle, but it helps to regulate calcium and phosphorus as well. And I'll talk about more of that later. It also is going to help in the regulation of acid-base balance, right? Which we've done a lot of things with acid-base, right? So we have experience with that. It's going to help in control of water balance and control of blood pressure. And those things sometimes go very much hand in hand. And we're going to talk about the hormones that affect that, as well as just the vascular that helps control those things as well. It is we talk about renal clearance, right? So this becomes extremely important when we're talking about a lot of medications. If you don't have good functioning kidneys, then you can't excrete not only water and urine, but waste products. And if you think about medications, right, that we need to be able to have the liver metabolize and then have the kidneys excrete. If you don't have good renal clearance, right, and we'll talk about the labs that you look at for that, then you can be in a lot of trouble, right? Now, some of the things on the bottom are things that you may not think about as much, right? But where we talk about regulation of red blood cell production, the kidneys actually produce and control erythropoiesis. And if you break that word down, erythro is red blood cell, right? Poiesis is when we create something, okay? So erythropoiesis is the hormone that we need to help create red blood cells. So when you don't have well-functioning kidneys, it doesn't just affect, water balance and urine and that kind of thing. It affects the production of red blood cells, okay? So people who have chronic kidney disease a lot of times also have anemia. And there's that link between the two, again, taking two body systems that are very much connected. The other thing is the synthesis of vitamin D. So the kidneys help to convert vitamin D to its active form, okay? And what that means then is if we don't have the active form of vitamin D, well, you guys remember you've done fluids and electrolytes, right? Vitamin D is needed in order to absorb calcium, okay? Also phosphorus, okay? So that is why when people have kidney disease, they have to be on a low phosphorus diet, okay? Because if they have kidney disease and they can't activate vitamin D, then they can't absorb the phosphorus, and then if they eat too much of it, it builds up in the system and it can cause a lot of problems, right? So then obviously people who have kidney disease can have issues with bone health as well, right? So again, all interconnected to think about. And the secretion of prostaglandins as well. And there's so many theories about all the things that prostaglandins do. So if you don't have well-functioning kidneys, then you might have issues with that as well. All right, so urine formation. Okay, so it's kind of crazy to think about, right? So each nephron is going to work on its own, right? Independently within its kidney, and each has its own blood supply. And so each kidney itself is going to work independently. And that's why if someone loses one kidney, they are still okay because they have one functioning kidney that works just on its own. The glomerular filtration. So this is when we talk about when we have when we talk about the kidney function tests, right? The three that you always want to be thinking about together are, and I know I've said this to you all before, glomerular filtration rate, and that is what this is talking about, the BUN and creatinine, okay? And they are an inverse relationship, but they are connected, right? Because the glomerular filtration is telling us how well are the kidneys filtering, and BUN and creatinine are the wastes. And so if you aren't filtering well, your waste products are going to be higher, okay? Now, this is kind of just giving you some numbers, right? I don't need you to memorize these numbers, but just understanding that 1 to 1,300 milliliters per minute of blood flow coming through, that is what the nephrons are filtering, and 180 liters of filtrate per day that it's creating. But we don't urinate 180 milliliters a day, right? So what needs to happen, right? And you can see this of 180 liters of filtrate that kidneys produce, right? 99% of it is reabsorbed back into the bloodstream, okay? So all that water comes back into our system. Remember, we have like 5 or 6 liters of fluid of blood, right? A lot of that is water, right? So all that water that we need to keep in the system, okay? But we do, about 1% of it lose through urine formation per day. So 1 to 2 liters of output per day is what is expected, okay? Just think about that. So, in clinical, when you're thinking about, doing strict diagnose and you're collecting urine, and if you have a patient that, only urinates one time on your shift, you want to be thinking about, again, not just that one shift, that one output that you're documenting, but how much is this patient having for output per day, knowing that you should have 1 to 2 liters per day. So you really want to be thinking about the big picture. All right. So for your questions, how much water is a healthy human body composed of? I wish I had you here to answer me, but the answer is around 60% in adults, okay? So a huge amount of the body is composed of water. And the second question is, what is a reliable means of determining overall fluid status? And I know you guys are so smart, and I know you're going to come up with the right answer, but the daily weight is the most accurate, right? And we know this, we've talked about, I taught you guys CHF, right? And that is why we teach our patients for daily weights, right? Because that is going to help us with overall fluid status. And just want to remember that, or think about this, 1 pound of weight gain is about 500 mLs of fluid retention, okay? So just think about that, right? So you have a bottle of Pepsi, a 1 liter, okay? Half of that, okay? So if we gain a pound, that means about a half of a liter of soda we have just hanging out extra in our body, okay? And again, thinking about more than one body system, right? The impact of that is on, the cardiac system is very, very important. All right, so moving on and talking about some, just of the technical stuff with the kidneys and the urinary system. All right, so we sometimes call it vasopressin, or you might know it as antidiuretic hormone. And so this is, again, something that the kidneys are responsible for. So in example, right, now, let me go on to osmolarity and osmolality first, because it's in the description of ADH, but osmolarity is just how much solute to water there is, okay? And osmolality is the number of osmoles, okay? So how much solute per kilogram of solution, right? And again, I do not want you to memorize this, but the kidneys, again, are going to help us regulate how much water is excreted, okay? And how do we do that, right? And I just said that 1 pound equals 500 mLs. And there's several ways that the kidneys help to do this, but antidiuretic hormone is extremely important, right? So in the situation when somebody is dehydrated, okay, the osmolality rises, okay? So what does that mean? So the amount of solute rises, right? So they're going to be more concentrated in their blood. So what happens is they increase the amount of antidiuretic hormone, okay, and that will then cause the body increased water reabsorption, okay, so that they're no longer going to be dehydrated, okay. Now, when there is excessive water, okay, and they are, like fluid volume overloaded, okay, the antidiuretic hormone is then going to be suppressed, less water is reabsorbed, and they're going to lead to more urination, more diuresis to try to help control that. When we talk about electrolytes, right? So we know that some of the big electrolytes that are affected here are sodium and potassium, where we are going to lose those through the loop of Henle, right? And that happens even more so when we have some meds on board, like furosemide, where they're going to lose a lot of sodium and potassium. But the kidneys are going to they're going to normally, when they're filtering the blood, they're going to say, okay, I need to get rid of the water, but I need to hang on to my sodium and potassium because those are essential for my body, right? Other things are angiotensin II and aldosterone, right? So we know that these are going to be released, okay, to try to increase water reabsorption, to try to then increase someone's blood pressure, okay? And that is done in a second way, right? So let me skip acid base for a second, but also with BP regulation. So vasorecta, those are capillaries that run alongside the loop of Henle. And what they do is they help with maintaining the osmotic gradient, and they help with the reabsorption of water and concentration of urine, so that you don't lose too much, and that is going to then help with BP regulation as well. Backing up to acid-base balance, we know as well too. Again, the urine has a certain pH, right? And the kidneys functions also to help with maintaining that pH balance. Now, renal clearance, right? So the kidneys are going to help to clear out the solutes and clear out the waste products, right? So renal clearance, how do we measure that, right? Now, we know that we can do serum blood work. So we can get a GFR, the BUN, and creatinine, right? So glomerular filtration rate, the BUN, and creatinine. Those we can draw from a serum blood test, okay? But the best way to determine renal clearance is actually from doing a 24-hour urine collection, okay? So when you're doing that, you'll find that they will, or if they order this, they're going to give you a light block bottle. Okay, so it's going to usually be a really big, like brown or orange container. You want to have the patient void, the first morning void, discard that. And then for 24 hours after that, you want to collect all of the urine and keep it in this light block bottle and put it on ice. Okay. And then after the urine has been collected for 24 hours, it goes to the lab and they do their magic. I don't know all of the, the science behind that, but from testing that urine over the 24-hour period, they're able to determine how well the kidneys are filtering, even more reliably measuring the GFR than the and the creatinine clearance than through the serum, right? So a lot of times you'll see you may see both of those tests ordered, okay? And that again, I know at least at Milford in their system, if you have certain medications that are nephrotoxic or even just harm, more harsh on the kidneys, when you scan that medication, a box will come up with the creatinine clearance on it. So you can get creatinine clearance. They can calculate that through a serum kidney function test as well, but it is more accurate if you do the through the 24-hour urine, but you don't see that as much, but you do still see the creatinine clearance come up. And if you want to you want to be thinking about that. If somebody has a really poor creatinine clearance, you want to be thinking about the meds that they're taking. Not only, being careful that you're not giving them something that's nephrotoxic and is going to hurt the kidneys further, but also how much of this medication that you're giving a patient, because if they're not able to clear it out of their system and they still have meds, on board, and then you are going to give them more of the medication, maybe they might end up with too much of the medication in their body. Maybe they need less of the medication if they're not able to clear it as well. So again, thinking about like gerontologically, which we're going to talk about, right? If an aging adult has less creatinine clearance, we know their kidneys function a little bit less as you get older. These are the kind of things you want to be thinking about with medication administration. All right. So I think I already kind of talked about this, right? But this is just kind of going over what I went through on that first slide, the importance of erythropoietin, vitamin D, and then also the ability to get rid of the waste products. This is just a funny picture for you guys to enjoy. It's actually kind of a bummer that we're not doing this in person because I, of course have some try to put a little humor in, and I had some commercial interludes for you to see, which we won't do here today. And I actually had a fun little case study. I don't know if I can figure out a way to do it, which it's a video case study and it is kind of funny, but if I can figure out a way to post that for you guys to be able to do it, I will. And if not, then sorry about that. Next, moving on to urine storage. So with urine storage, so again, the bladder is really just like a holding tank, right? But it has a lot of control by the nervous system, right? And so there's the sympathetic and the parasympathetic system. Okay. Now the bladder's going to fill, and like we said, the bladder has the ability to expand and then contract, right? Around 150 to 200 is when you feel like you need to void, and it starts to feel much more uncomfortable as you get to the 500 range. Usually, and again, this is people who don't have any urinary issues, but can usually hold for several hours and overnight, right? So, and you guys learned with the pediatric, if you have bedtime wetting, right? Bedwetting in children called enuresis, right? Because they don't have the inability to hold it overnight, and that can be for several reasons. It's normal, growth and development, but then you might have that also outside of that range in the pediatric population, and that can occur for different reasons. That is not normal. But vasopressin or antidiuretic hormone is going to increase overnight as you are not taking in as much water when you're sleeping, right? And so it tries to preserve the body's water overnight that it needs. And that's why you're then able to, sleep through the night and not have to get up and go to the bathroom. All right, so micturition, right? So the this is just a fancy term, right? We like to use like all kinds of words, right? Even voiding is more a medical term, but micturition is also another word that we use. And this is, you know, how does this happen, right? And again, I don't really care that you have any of the details of this, but you just knowing that the nervous system is what causes this to happen, right? And here I'm just making sure that, yeah, I didn't miss anything because I got little notes over here too. But the pelvic nerve stimulates the bladder to contract, right? And then the urethra has to relax. The detrusor muscle, right, which is at the neck of the bladder, contracts, and that is what then the urethra opens and urine flows out, right? So just thinking about this, a couple things. First of all, and you guys haven't done spinal cord injuries yet, but you will, there are neurological conditions that are considerations to think about, right? So if somebody has a spinal cord injury, the voluntary control to be able to, say, oh, I'm going to need to go to the bathroom and to urinate now, that is lost, but that involuntary control is still there. And then the reflex is maintained and the urine comes out, right? But a lot of times that's why, because there is not that reflex, people with spinal cord injuries, they still have, they may not have the feeling, but you will be straight cast and things like that to get the urine out. Because they no longer can voluntarily control to try to go to urinate. So they might be incontinent, or they could be straight cast because they cannot control it, but they obviously are still creating that urine. Another consideration with that, wait, what was I going to say? I just forgot. I can't remember. I lost it. Anyways, that happens to me quite a bit. Oh, I know what I was going to say was sometimes you guys have had the experience where people have a catheter in and they feel like they still need to go to the bathroom, right? And they're pushing against their catheter, right? And that's because of spasms that still occur. Because again, there's a lot of the nervous system, a lot of nerves, and especially that in that detrusor muscle, and that's what makes them, when that spasms or their bladder spasms, that makes them feel like they have to go even when they have a catheter in place. All right, so this is that urinalysis cheat sheet that I told you about, right? And you want to pay attention to this so we know what normal urine is supposed to look like, right? Nice yellow. We want it to be clear. We don't want it to be cloudy. We don't want abnormal colors. We know that there could be blood in their urine. It could be because of something like bilirubin, but it could be a med, it could be infection. There's a lot of reasons why the color would change. It should not have a foul smelling odor, right? And again, most of the things, right? What is normal, right? So there shouldn't really be much protein in our urine. There shouldn't be sugar. There shouldn't be ketones. There shouldn't be bilirubin, right? Those are the things, we shouldn't have casts, right? We keep going here. I don't know if I can't move it down, but you don't want these things, right? You don't want to have blood, or we don't want to have very, very little blood or found in our urine, or white blood cells in our urine, or organisms in our urine, right? Now there are bacteria might be on around the urethra, which then you could find in your urine, but there should not be any bacteria from your bladder. Your bladder is a sterile organ. So if bacteria is in the bladder and in the urine, then that's when somebody has a UTI, right? Thinking about the specific gravity, all right? So this is a number that might be important to know, right? 1.03 to 1.030, okay? And so if it is less dilute, or if it is less dilute, we're going to have a lower specific gravity. If it is very concentrated, then it's going to be higher specific gravity, and that's not normal, right? So we want to be right within that kind of normal range to know that somebody isn't dehydrated, or somebody's not. It can just be about dehydration, but it also could be about kidney function, right? So if somebody doesn't have the ability to create the urine formation correctly because it is not filtering correctly, then it also can affect the specific gravity, okay? So again, understanding about a urinalysis is important. All right, now going on to gerontological considerations. So the as you get older, things are just going to change, right? And because things change and things just kind of slow down and the function and the structure changes, they are more susceptible to kidney injury. Okay, so just like we talked about already in the cardiac system, that you can have sclerosis, right, where sclerosis of your vasculature. So that can also happen in the renal vasculature, okay? Because, right, we can't have it just be in one part. It's a systemic thing, so it's going to affect renal vasculature as well. If you have decreased renal vasculature, you're going to have decreased blood flow, okay? If you have decreased blood flow, that is going to result in decreased glomerular filtration rate, okay? And if you can see this at age 35 to 40, okay, that's when it starts, okay? So the older you're going to get, the worse it's going to get. It also affects tubal function, acid-base balance. We aren't able to empty the bladder as well, right? So all our musculature is going to decrease in ability. And if you don't have the musculature, that detrusor muscle, to get all the urine out, then the bladder doesn't empty, and that's urinary stasis, right? And if you have urinary stasis, you're at more risk for infection, et cetera, with that urinary retention. Part of why that happens is because the nerve innervations also are decreased, right? So that urge or that feeling to void is decreased as well. Okay. Now, because of all of these things, if the bladder is also not just the bladder, but if the kidneys are not functioning as well, then you have decreased ability to clear out drugs, which I talked about, right? And then that also can lead to issues with more of like drug interactions if you have more of that left in your system. It is in an older adult. It is not unusual to have about 50 to 100 mLs of urine that's left over in the bladder after you've voided, okay? But some of the things like decreased bladder compliance, we just talked about, incomplete emptying, people who have benign prostatic hyperplasia, which you learned about last semester, they have urinary retention issues, decreased estrogen. So women who are at the age of menopause, especially, will then begin to lose bladder compliance and have incomplete emptying, and can lead to urinary incontinence. So these are all issues. You also have decreased vasopressin, which leads to issues with glomerular filtration rate. Older people having less thirst, obviously going to have an impact on the fluid intake and fluid and electrolyte issues. All right, so the assessment of the urinary system and health history, right? You can refer to the table as well to look at this in more detail, but the things that you want to be looking at and asking, right? So a lot of the things with the urinary system are things you have to ask your patients, right? It's not just about what you see, but it's going to be what you ask, right? You want to ask about pain, and we did teach you with the physical assessment, right? CVA tenderness, right? Everybody remember that technique, okay? But a lot of times with kidney disease, which we'll talk about the different kidney diseases, you can have pain. Also, changes in voiding, and you want to know what all of these things are, right? So are they going too often? Do they have increased urge? Do they have dysuria, painful urination, or hesitancy, right? Do they have difficulty starting the flow of urine? Do they have incontinence, enuresis, bedtime wetting, polyuria, so a lot of urine, oliguria, not enough, right? Or hematuria, blood in their urine. So those are all changes in voiding patterns that you want to know about. GI systems, right? Because they have a lot of the shared autonomic, right? So the nervous system and sensory innervation. Have they had any nausea, vomiting, diarrhea, abdominal pain, distension, right? Because those could also, a lot of times GI and GU symptoms look alike. And when you're trying to rule out what is going on, you need to be asking about those GI symptoms too. Unexplained anemia, because remember the role of erythropoiesis, and past medical history. Because again, the role of what happens in, like diabetes, which is going to affect, can affect, or cardiac, how they go together and affect the a vasculature, right? All of those things can then lead to worsening of genitourinary disorders. Again, the physical assessment, looking at the costovertebral angle and percussing, checking for pain. Because the renal artery is what supplies the blood, you want to look for bruits, right? Because they can be stenosed. You can have aneurysms in those renal arteries, right? Looking for ascites even. Post-void residual, so especially people who have retention, you might be doing a bladder scan and checking post-void residuals, knowing what the normal amount in an adult would only be about 50 or 100 that should be left. If you are checking, because if somebody has urinary symptoms that are associated with BPH, you want to, you can check for BPH with, as you know, different blood work, but also as a digital rectal exam, and monitoring for edema or changes in weight, which we said daily weight is going to be one of the best indicators for fluid status. Diagnostic studies. So there are a ton of them, right? So we talked about urinalysis, which is going to tell us about the composition of the urine. And then certainly if we think there's infection, we're going to send off some of that urine for culture. And there are a lot of organisms that can be tested for. Renal function tests, which I've mentioned before, GFR, BUN, creatinine, creatinine clearance through a 24-hour urine as well. And then all the different scans, right? So doing ultrasounds, CAT scans, and MRI, nuclear scans if you're worried about mass or trauma, endoscopic. So within the urinary system, we would be talking about a cystoscopy, which would be going up through the urethra to look at the bladder is common. Looking on the right-hand side, these I'm not going to go into, quite as much, but cystoscopy is, again, to visualize the bladder. Kidney biopsies are going to be things that you're going to look at for, obviously, malignancies, also nephritis as well. If you think that you might have different issues with the what am I trying to say? Blood flow, things like that. You might be doing some of the different types of like urographies. KUB is going to help us check, which stands for kidneys, urethra, ureter, and bladder. Help for looking for stones, which we're going to get into a little bit. CAT scan and MRIs are going to be good if we're looking for tumors and things like that, and structural changes, etc. And I think that's all I really want to say about that. Oh, one other thing though too is for some of these tests you want to think about for them to have, especially if they're invasive, think about if somebody is on anticoagulants. So they would have to hold those to have those tests, which gets into other issues of risk because of what they are on their anticoagulants for. And post diagnostics as nursing interventions, thinking about watching for bleeding, etc., infection. If someone's having a biopsy, a lot of times they might, they're going to be required to have rest after. So just thinking about those nursing interventions. This is, oh, I just said this, right? Sorry, I got ahead of myself, but these are going to be the most common procedures that are going to be used to, visualize the kidney and the bladder, testing for the different disorders. With kidney biopsies, just so they can sometimes go in through with a needle, or they might have to make an incision through the flank area. So that is why, the risk of bleeding, etc., is higher, and why they'd have to hold their anticoagulants. Okay, so now we're going to move on to infections. So the first types of infections we're going to talk about are lower urinary tract infections. So those would include cystitis, prostatitis, urethritis, right? We've talked about UTIs, certainly. And they're the second most common infection of the body. We're going to talk about the upper GU infections after. But typically the bladder is able to clear bacteria, but the problem is when it comes back up, right? So, the age-old, thing that you want to teach patients of wiping from front to back so that you don't introduce bacteria then into the urethra, which then can travel back upwards and get into the bladder, right? Because remember what I said, the bladder should be a sterile holding device. And we shouldn't have bacteria there, but it certainly can travel up. It's another reason why, catheters, we can introduce bacteria into the bladder. If somebody has routes of infection, right? So transurethral, which we just talked about, they can also have, if they were, have a bloodstream infection, certainly then it can pass into the bladder, or a fistula, right? So if somebody has like an anal fistula, right, or some other type of fistula, you could have bacteria then move into the bladder and be the source of infection. I think we all know what symptoms of UTI are like, right? So feeling burning, frequency, the need, increased urgency, going to the bathroom overnight, someone being incontinent, pain, whether it's suprapubic, so above the pubic area, in the pelvic area, or even in the back, having blood in their urine. And then sometimes patients don't even realize and are asymptomatic. Now, again, this is a very common infection in older adults, more male than female, for all of the reasons that we talked about already. The inability to maybe feel or have decreased bladder tone, not being able to empty, not having like with diabetes, right? Just like you have neuropathy in the feet, they can have autonomic neuropathy, which then affects the bladder, and they're not able to empty. Urinary stasis, that increases the risk of UTI, and huge increased rate if people have catheters, which are certainly more people, older people are likely to have catheters than younger people. So really important to just think about hydration, keeping people hydrated, keeping people decreasing risk for infection, keeping less use of catheters, certainly being using sterile technique if we do need to use catheter. We want to think about also cleanliness of the with the urinary system. We want to think about keeping patients clean as well if they have catheters, right? Because remember, we talked about the transurethral contamination with bacteria. And also thinking about if patients have less urinary ability to hold their urine, if there's incontinence, then especially with the elderly, we're thinking about incontinence, and then even a safety risk for falls with incontinence, or even the people having increased urgency trying to get up or getting up in the middle of the night more, just increases their risk for falls. So things that we really, need to be thinking about. Now, how do we know? What do we do? What do we test? So urinalysis, which we already talked about, what's included in that test. If we send off that culture as well, we look for a cellular, whether or not there's hematuria, whether or not there's pyuria or white blood cells as well in the urine. They can do a urine dipstick study in the hospital. I don't really see that as much, maybe in long-term care settings. You also want to look and see if rule out other things, like do STI testing to see if those could also be the source of the symptoms that they're having, so that you don't make sure you don't, misdiagnose or miss something. And again, if it doesn't resolve, or you're thinking that there's some other differential diagnosis, certainly doing additional scans and x-rays and ultrasounds, like we just went over the diagnostics, would be indicated. Now, doing a urine culture, so this should be what's called a clean catch, right, or midstream. So you usually typically have, the wipes that you're going to use. You want somebody to, this is best if it's the first morning void, right? You want to have them clean, right? So you're reducing the amount of bacteria from just the outside of the urethra that would get in and contaminate the specimen. You want them to start the flow and feel that flow of urine, stop, then catch the urine, and finish with your cup, close it up, make sure you are labeling it appropriately, and get it to the lab. Okay. Now, if you look here, a sterile specimen cup with 5 to 10 mLs of urine. So you don't need to fill half of a cup, right? Now, certainly if they are able to go, I would take more than, and I would never do more than less than 10 mLs, but you don't need a ton of urine to be able to catch a specimen for culture. Whoops, skipped over one. Make sure I didn't miss. No, I did. So now talking about if we know somebody has a urinary tract infection. So when it's an acute infection, typically you're going to have a 3 to 7 day course of antibiotics. I did put on the med sheet, so you can just look at that for the antibiotics to kind of focus on. And then long term. So a lot of times people have recurrent urinary tract infections, and so they may be on another shorter course of antibiotics. And in worst case scenarios, there are some patients that will be on long-term antibiotics for your UTIs. And cranberry juice, right? So cranberry juice is not going to cure a UTI, but it can help with the symptoms that patients feel. Sometimes patients take cranberry capsules as well. And with the nursing process, right, with UTIs, okay, so we know that a lot of times it's pain. People may not understand ways to prevent UTI, so you want to educate them about that. You want to help give, medication not only for the treating the cause, right, which would be for using the antibiotics, but also helping with the symptoms. So phenazopyridine helps with the pain and burning during a UTI. That's on your list of meds to know. And again, self-care, just really like the cleaning process, that's in hydration, those types of things. And again, gave you some charts to refer to. I'm not going to answer this one for you. I want you to figure this one out for yourself. What are patients with UTI at risk for? And now we're going to move into the upper urinary tract infections. So we're going to talk about acute and chronic pyelonephritis. So this is just like what it sounds, right? So this is going to be infections that are in the higher part, the upper part of the urinary tract. So now we're talking about the kidneys, right? So the renal pelvis, tubules, and the interstitial tissues of the kidneys can be assaulted and caused from bacteria and cause an infection. So with these patients, they are more likely to have a little bit different systemic symptoms, right? So they can present with chills, fever, leukocytosis, right? So increased white blood count, bacteria in their urine would show up, pyuria, right? So that can be actually pus in their urine, flank, or so that side where the kidneys are, or low back pain, nausea, vomiting, headache, malaise, and painful urination, okay? This is going to be diagnosed through urine culture, but also typically looking and visualizing through CAT scan or ultrasound pyelogram, right? Looking at the more at the kidneys. This again, even though this is a different part that is infected, the treatment is typically going to be the same, except it's a longer course of antibiotics. Cultures are going to be how they determine whether or not it's cleared. It's very, very important that they have the really, really well hydrated to try to kind of keep that flushed out. I think that's all I wanted to say on that. And you can see here in this picture, right? You can see this is going to be your normal kidney, right? And then one with pyelonephritis. You can see here all of the inflammation that is occurring within the kidneys. Now, people can have also chronic pyelonephritis, right? And sometimes they might have this, but they don't have signs and symptoms until they actually have an exacerbation of the pyelonephritis. Things that they'll do to diagnose, looking at kidney function, right? And looking at through the IV urogram, looking at the flow through the kidneys, looking at for inflammation. Now, if somebody has chronic pyelonephritis, just like inflammation that's chronic anywhere, if you continue to have inflammation over and over and over again, that can lead to scarring. If you have scarring in your kidney, then your kidney is not going to function as well, and it can lead to more kind of chronic kidney disease. Again, treatment is just long-term antibiotics, and if they are hospitalized for this, then they would be on fluids, IV, helping to kind of flush that out. and all of the other, self-care things, also hygiene, cleanliness, all those things to try to prevent exacerbations is important to be teaching our patients. Okay, so we're moving on to, we're getting there, we're close, on to urolithiasis and nephrolithiasis. And what is this? This is stones, right? So stones that develop, and you can have them in a lot of areas of the body develop. And people who are not mobile, people who have a lot of urinary stasis, right? People with infection are more favorable to, are susceptible to the formation of stones. There's a lot of different types of stones. So you can see here calcium oxalate, calcium phosphate, uric acid. Those are the different types of stones. Now, most of the time, regardless of what the type of stone, the symptoms are still going to be the same, okay? And where the stone lands, where it is, the size of it, that is going to then also depend on the type of like manifestations or signs and symptoms that they have. Now, if it is less than a centimeter in size, usually a patient can pass it. If a patient is not able to pass it, and I just want to give you a visual. Someone said this to me once, but trying to pass a stone is like trying to pass a jagged rock through a strand of spaghetti, okay? And that strand of spaghetti, which is our ureters, right, are innervated, right? We talked about that there's a lot of nerves, right, that are helping, that are part of and control the urinary system. And so if you think about that, something that is innervated with nerves, and now you're going to pass this jagged, raggedy rock through, that is excruciating, right? And that is why people who have kidney stones or nephrolithiasis are in so much pain, right? So they can typically have CVA tenderness in that renal area. That's why we do the percussion. Pain, if that's jagged going through a small passaging through the ureter, that can cause trauma, and that's why we have bleeding because of the pain too. A lot of times patients have can have nausea and vomiting, okay? Now with this as well, they'll do CAT scans to look at where are the stones and to be able to measure chemistries and stones. As chemistries can help, like determine like if you have high uric acid, right? Which we've already talked about. Gout, people are uricemia, high amounts of uric acid in the urine or in the blood to help us determine what type of stone it is. And then after you pass the stone, whatever type it is, you want to know what it is, right? Because if there is recommendations, if you know what type of stone it is, you can make further recommendations for, diet changes and etc. But here are the different areas you can have in stones, right? So you can see there they can collect and develop in the kidneys themselves in for renal stones, right there in the ureter or also in the bladder, okay? So lots of places where they can develop. These are the different types of urinary stones. And again, take a look at the shape of those stones, okay? Just imagine trying to pass those, right? And this is a good slide to take a look at too, right? What are they made of? What are some things that, are potential risk factors for what makes, and then what makes sense that you might want to avoid or decrease if you were thinking about like a calcium stone or a uric acid stone. What kind of diet recommendations might you make for a patient? So medical management, right? We want to get rid of that stone, right? So it's important we figure out the type. We want to make sure that we don't have damage like to our ureters. If it's a very large stone, we wouldn't want it to pass. So they might try to break those stones up before they're going to pass. You want to certainly control if it's caused an infection, right? So like if you've had a stone that's been in the renal, in the kidneys for a very long time. Actually, this happened to my mom's husband. He became septic. They thought they could not find the source of infection. And what it ended up being is he had kidney stones that they said were fine. They were stable. They were small. They'd been there for a very, very long time. And they actually did, he ended up having when they went in to go grab the kidney stones, they were covered in pus, and it is what had caused him to go septic. So, that sometimes there is infection involved in that. And certainly if a stone is large enough, right, and it tries to pass and it can't get through, it can cause obstruction. So then a backup into the kidneys and can cause acute kidney injury. And those are things that you're going to talk about in nursing for, but we don't want that to happen. It's very painful. It's very dangerous. It can cause a kidney injury. So we want to make sure that we break up the stones, get them out, pass them before you have an issue. The other thing is that, again, we talked about is that there is extreme pain a lot of times with this. So trying to fix the cause if we can, but in the interim period of time, especially if somebody is just naturally trying to pass the stone, a lot of times they do require pain medication and liberal fluid intake. So trying to just, help them to pass it out. Okay, here you can see calcium stones. So again, it's a little controversial whether or not restricting calcium actually helps with reducing calcium stones. But I say that someone who, I don't know, I am not a urologist, but if I could do anything that might even potentially help, knowing how much pain it is to have a stone, I probably would follow that. Uric acid stones, you want to follow a low purine diet. Cysteine stones, a low protein diet, increase your fluid intake, things that will help to alkalinize the urine, and oxalate stones. Limit oxalate intake, decrease urinary excretion of oxalate, and increase fluid intake. All right, so if you are trying to break up the stones, kidney or urolithiasis or nephrolithiasis, there are some things that they can do, right? So they can do what's called lithotripsy, which are shock waves, okay? It's non-invasive, and what it does is from the outside of the body, it actually uses shock waves to kind of, and it sounds like a banging, okay? And that banging actually, what it's supposed to do is like pulverize the stones on the inside. I don't know if you've ever been to anywhere where you can actually feel the vibration, right? But that vibration feeling from sound, right? Like if you were at a really, really long, loud concert and you can like feel that vibration, well, imagine that like, multiplied by many. And what it does is try to fragment the stones in the kidneys to try to make them smaller so that you can pass them. And fragment them even to like a grit or sand that you're then passing out the pieces, right? So after somebody has had lithotripsy, or even after someone is just trying to pass a stone, you always, always, always want to strain their urine, okay? You want to strain the urine, get whatever stone is left, whatever that is, put that in the cup and you send it to the lab for analysis. So again, we can figure out what type of stone so we can advise them better. Okay, a ureteroscopy, again, we'll go in using a scope and a laser to try to break up the stone. And sometimes if the ureters, if there's an issue, especially with obstruction, or they think there might be, they might put a stent in place that will be typically going to just be a temporary stent placement that then helps the stone to be able to pass, and then the stents will be removed later. And then if they want to go in and actually extract the stone, then they can do percutaneous, like with a big needle through the skin, right? Nephrolithotomy, where they go into the actual parenchyma, into the heart or inside of the kidney and pull the stone out. Okay. Now, because we have these less invasive methods to remove stones, they don't typically have to do the surgical management like they used to. So most people have lithotripsy as well. But if it is sometimes because of an anatomical nature, something with the structure that is causing these stones, or stones to not be able to pass, then perhaps someone might go in and do surgery to repair that. This is just showing you, they use a cystoscopy to get to the ureter, and you can see that is what you're seeing here, the cystoscope going in through, it looks like a male through the penis, going into the bladder. Here is what it looks like, through the urethral opening, and actually just like extracting the stone. Here's a picture showing you what that lithotripsy looks like, right? So they can tell, use X-ray to kind of tell where it is. And then underneath, you can see where that, here, let's see, here, I'm pointing with my finger like you could see it. This is the part that's going to, like a jackhammer, is going to be kind of with sound, right? With shock waves, right? Not actually hurting the patient physically, right? But those shock waves are going to be delivered to right where the stones would be in the kidneys to help break them up. All right, moving on to urinary tract cancers and bladder cancers. I don't know why this one is so small, right? I gotta make it a little bigger so I can even see it with my glasses here. But risks, genetic mutations, exposures. So a lot of times exposures to radiation, occupational exposures, family history, all put people at risk for bladder cancer. And then of course here in bold is smoking, right? Now, one of the big things, the takeaway here is that when people have painless hematuria. Okay, so people who have hematuria and have a UTI a lot of times have pain. Okay, but if you just have painless hematuria, this is one of the really big red flags for bladder cancer. Okay, also, changes in urination, back pain, those things, though, changes in urination, those are also going to be signs and symptoms. Back pain and pelvic pain is typically when there is metastasis, right? Because if it has metastasized from the bladder to the kidneys, especially, you can end up with that pelvic or back pain. How they would diagnose this, and this again, you've learned cancer already, but you know that there's going to be diagnostics, whether it's CAT scan, MRI, ultrasound, biopsy is what is going to be done to positively diagnose that there's a malignancy. Treatments. So treatments are going to be, again, dependent on grade and stage, just like So whether it's surgical, whether or not it's chemical, or chemo or radiation. They also use, so for surgical, they're able to do a lot of robotic surgeries to, whether they remove part or all of the bladder, which is why we're going to talk about urinary diversions after. But that is one treatment. Pharmacologically, they can do chemotherapy where they instill the chemotherapy right into the bladder. That's called intravesical, or they can use typical, chemotherapy, which is going to go through the systemic system into the bladder's arterial blood supply and then get to the bladder. Also, there's an immunologic BCG live, which is used for recurrent bladder cancers, and then radiation. When surgery is an option, sometimes they'll do chemo and radiation, just like you have learned about with all the other cancers that you've talked about. Oh, now I gotta make it smaller so I can, there we go. So if they needed to remove the bladder, to a new site, then they can create urinary diversions, right? So this is going to be just like we talked about with the GI system, right? So they're going to divert the urine. So they bring the ureter instead. So if they've removed the bladder, then now the kidneys are still connected to the ureter, and the urine is going to be brought out to the outside of the body, usually creating a stoma. And that's what they'll call the, through the abdominal wall. And that's what they will call an ileal conduit. So all the things that we know about stomas and we know about colostomies and things like that, those are all going to be the case with an ileal conduit too. Especially if it's brand new, we need to be monitoring the stoma, how it looks, what's making sure it still has a good blood supply. We're monitoring also what is coming out. We're monitoring, I&O. Sometimes we might have to irrigate it, right? A wound ostomy nurse is going to be helpful, especially helping them learning at first with their ostomy care and, changing the bag, etc. I think most of you have experience with that, or we've certainly talked about it as well in the last GI lecture. So there's different types, right, of urinary diversions. So so the cutaneous ureterostomy is the one through the abdominal wall with the stoma, and you're going to have a bag just like you thought you've seen before. And then I do have a picture, right? So there also is a continent ileal urinary reservoir. So what happens here, you can see here, so this is, oh, I thought I had it here. No, I guess I don't. Oh, I thought I did, but with the continent urinary reservoir, what happens is they actually create almost like a pouch, right? So on the inside, and they still have to catheterize it, right? But they've created it using their intestinal wall to create like a little pouch where they hold their urine. So essentially, like the intestines are creating a new bladder, right? If they've had to remove the urine. So you must then go in and catheterize it and drain it, just like you would if somebody had needed a regular catheterization. And then the ureterosigmoidostomy, the ureters are transplanted into the sigmoid colon, and then urine flows out of the rectum. I gotta say, I have never seen this myself, but that is an interesting concept. So here you can see some different types of the ileal conduits, right? Urostomies, vesicostomies, and nephrostomies, okay? So sometimes, I think probably nephrostomies are the ones that you see most often, right? Where a catheter is put into the renal pelvis, in the flank area, into the kidneys, and then the tube is what is coming on the outside of the body, and there's a bag for you to empty as well. All right, now this very last slide has a lot of, these are the male reproductive disorders, conditions affecting the penis, and some of these you have already done with either maternity or pediatrics, and some of them are not going to be covered at all. So the only ones, and some of them are not even on here that you need. So I just want to bring you back to the three. I'm going to bring you to that other. I made that separate document for you, which I just got to open one more time. Sorry, gotta get to it. Here we go. I made a separate document for the 3 male structural disorders that you are responsible for on this test, and that's going to be phimosis, right? So phimosis is where the foreskin of the penis cannot be retracted over the glands, okay? And again, a lot of times this is things that it's normal in small children and then resolves with age, but it can be also due to something pathological, infection, inflammation, or scarring. And this, what happens, it makes it more difficult for the men to urinate and lead to recurrent infections. If it is a physiological condition, it typically, they can gently retract it over time to help improve this. And if it's topical corticosteroids can help if it's inflammatory, and circumcision might be required if it is not able to resolve on want own. You want to make sure that you don't forcefully retract, because that can obviously be very painful for males and also lead to more inflammation and scarring. You want to make sure people understand about how this developed, and also looking out for knowing signs of infection. Cryptochordism is when one or both of the testes do not descend into the scrotum. And you may have talked about this with in maternity. I'm not sure if you did or not, to be honest with you. But a lot of times, with prematurity, right? Because they just haven't descended yet, that can happen. It can also be due to some hormonal or anatomical abnormalities as well. With cryptochordism, there is risk for infertility, testicular cancer, inguinal hernia, or a testicular torsion, which is meaning the twisting of the it. it needs to be, they can usually diagnose it by physical exam. So that's why you'll see you'll roll the scrotum to feel, especially when they're newborns, right? You kind of like roll the scrotum inside of your, with your gloved hand and feeling for the testes in the sac to make sure they've descended. If you can't palpate it, then ultrasound to diagnose it. You watch to see if it actually ends up being, something that's just delayed and it will descend over time. Or if not, then surgery can be done to bring it down. And again, ideal to get that done early, so under a year. You want to make sure that you are monitoring for complications, and if they have surgery, any of the post-op complications that we would normally look out for. And lastly is hydrocele. So hydrocele is when there's fluid in the scrotal sac around the testes, okay? And you can have the two different types. Don't worry about that. But typically symptoms are just going to be painless, but scrotal swelling. So usually you're just going to see that, right? That enlarged scrotum. They do what's called a translumination test. They do ultrasound, and with the translumination test that they can see when there's a buildup of fluid in there. For infants, it could resolve on its own. Otherwise, if it's very large, they might need to have a surgical procedure for that. You want to make sure that it's not a hernia. So you want to make sure that you're accurately diagnosing this, and make sure that you educate your parents about the complications, because a lot of times it's small children. And if they have post-op surgery, then monitoring for post-op infection. So with all of these, because most of them are going to be present from birth, you want to make sure that you are doing good assessments, and this is being discovered early on so that timely intervention can happen. Educating our parents about what to look out for, especially if they're older, making sure that knowing that this is a sensitive area and sensitive topic, so maintaining their privacy and being sensitive. And depending on what age they are too, making sure that we are using age appropriate explanations, and also involving the caregivers when we're making our plan of care. All right, so that is it. I'm not even sure how long this ended up being, but that is your entire GU lecture. So again, make sure that you watch this, make sure you look at your notes and all of the little extras that I have posted for you guys. All right, good luck in your studies.